Okay, well, we're just going to get started and start the intro, and everybody can join as we move along. I'd like to, first of all, say I'm sorry, my camera doesn't seem to be working, and that's me, the little Canadian Public Health icon there. I'd like to welcome everybody today. Welcome, bienvenue, pijashig, to the February edition of the Public Health Virtual Journal Club. I'm Danielle Tremblay, and I'm CPHA's Communications Manager. I'd like to open today with a land acknowledgement. While we're all coming together from different parts of Turtle Island, CPHA's office and my home are located on the unceded territory of the Algonquin Anishinaabe Nation. CPHA is committed to meaningful truth and reconciliation with all First Nations, Métis, and Inuit peoples, and to that end, has established an Indigenous Advisory Council to guide its path towards reconciliation. It's now my pleasure to introduce Monica Emode, who is our student member of CPHA's Board of Directors, who will moderate today's session. Over to you, Monica.
I just want to make sure my microphone was on. Hi, Danielle. Thank you, Danielle. So at CVHA, one key area of our work is to advocate for public health, speaking up for people and populations to all levels of government. We champion health equity, social justice, and evidence-informed decision-making. We're a catalyst for change that improves health and well-being for all, and our vision is a healthy and just world, and our mission is to enhance the health of people in Canada and contribute to a healthier and more equitable world. So the Canadian Journal of Public Health is an independent journal that publishes peer-reviewed original research and scholarly articles submitted in either English or French that are relevant to population and public health. This journal aims to advocate for public health research and practice in Canada around the world, contributing to improvement of the health in populations and the reduction of health inequities. And you can follow CPHA's Twitter here at CGPH_RCSP. So for the past 4 years, we've been holding a webinar series to engage our members. So initially, this series was primarily intended for students, trainees, and early career professionals with the goal of promoting public health careers. You can find the recordings from these past sessions on our YouTube channel. And so this year, we are holding a series in partnership with the peer review journal that we publish, the Canadian Journal of Public Health. And so each month, a graduate student will critically appraise a different journal article and will engage the paper's author in discussion. A committee of devoted volunteers have identified the 8 papers that we've chosen for this year, and registration to these webinars will open a month prior to them taking place. So our hope is that this Journal Club session, these series, will provide a supportive learning environment for you guys as participants to keep abreast of the current public health literature, develop skills and competencies in critical appraisal, and expose participants to a range of methodologies and analytical approaches used in public health research. We hope that you find these sessions to be invaluable throughout the year. And we hope that you follow along in this conversation on Twitter at CJPH_JClub. And so I'm looking forward to another very exciting webinar presentation and a thoughtful discussion. But before we begin, just a few housekeeping items. And so all participants are muted, but we hope to engage you through either webinar, through polls and other features. And so the toolbar at the bottom of your screen will have a few features. So if you have any general comments, please post them in the chat box, and this will be visible to all attendees. And we encourage you also chat amongst yourselves on Twitter so we can continue the conversation there after the webinar is over. We always find that we have lots of discussion happening. And if you have any questions for the presenters, please post these in the Q&A box, which is going to be visible to all presenters. So your questions will be answered in sequence. And just a reminder that this webinar is being recorded, and the recording will be available to all of our members at CPHA and registered participants following today's meeting, and will be available more broadly within 3 months. And so just some polls so that we can get started. And the first question is, where are you at on your education and career path? So very excited to see lots of PhD and early career students. Very exciting. And for today's session, what's the primary interest for today's paper discussion? So it seems like we have a really good mix, which is really nice because we have lots of expertise in the room for all of these things. So I'm very excited. So without further ado, I'm very excited to introduce you guys to today's speakers. So our presenter is Samantha Genham, who's a public health professional with graduate training and epidemiology and who has broad experience in research and policy. She currently works as a policy analyst in the Social Determinants of Health Division at the Public Health Agency of Canada. She has already worked in various research and policy positions at Diabetes Canada, Health Canada, and the Canadian Institutes of Health Research. She's completed a Master of Science in Public Health with specialization in epidemiology at McGill University and an Honours Bachelor in the Health Sciences at the University of Ottawa. Our lead author, Dr. Anna Jakova, is an Associate Professor of Sociology at the University of Western Ontario. Her research centers on population health, trends over time, and disparities across population groups. Over the course of the pandemic, she has co-authored studies on mortality and health behavior impacts of COVID. We also have Anthony Jen, who is a doctoral candidate studying sociology at the University of Western Ontario. His research focuses on social determinants of adult health. He is particularly interested in assessing how experience in post-secondary education influence health and health behaviors. And Matthew Stackhouse, who is a doctoral student studying sociology at the University of Western Ontario. His research focuses on social determinants of health and health across life course. Matthew is particularly interested in examining how early life conditions shape health and health behavior trajectories. We also have Dr. Patrick Denise, who is an assistant professor of sociology at the University of Western Ontario. He researches inequality in education in the workplace. Some of his current work looks at school choice policies to improve or make worse patterns of segregation in urban public education systems. He's also interested in students' non-traditional pathways to and through post-secondary education, as well as in how workplace institutions and policies shape workplace workers' wages. And Dr. Howard Ramos, who is the chair of the Department of Sociology at Western University. He's a political sociologist who investigates issues of social justice and equity. He has published on immigration, race, ethnicity, urban studies, social movements, human rights, Indigenous mobilization, and environmental advocacy. So without further ado, I'll pass this along to Samantha to begin her presentation.
Okay, great. Thank you for that introduction. As mentioned today, I'll be presenting the article Changes in Health Behaviors During Early COVID-19 and Socio-Demographic Disparities, a Cross-Sectional Analysis. So I'll spend about 10 minutes going over the introduction, methods, results, and discussion of the paper, and we'll leave the rest of the time for a Q&A and discussion with the authors. So to start off with some context for the paper, as we have seen over the past year, the COVID-19 pandemic has magnified systemic issues and longstanding inequalities that have disproportionately affected Canada's most stigmatized and marginalized populations. We know that certain groups, such as racialized populations and people living with low socioeconomic status, are overrepresented in reported COVID-19 cases and deaths, and that there are a number of structural determinants such as population density and working conditions that play a role in this regard. We've also seen that the pandemic and its various public health measures, such as physical distancing, have differentially impacted Canadians' physical, behavioral, mental, and social well-being. So notably, we've seen that Canadians' health behaviors have changed during the early stages of the pandemic. For example, a report published by Statistics Canada found that Canadians experiencing low self-perceived mental health during COVID-19 are more likely to report increased use of cannabis, alcohol, and tobacco. So the objectives of this study were twofold. First, the authors sought to provide national estimates of changes in alcohol, tobacco, and cannabis use, junk food consumption, and inactive screen time. And this is important since it provides a more comprehensive understanding of how the pandemic has impacted Canadians' health behaviors and addresses multiple behaviors in one analysis, which is great for comparing the different behavioral changes. Second, the authors sought to examine the socio-demographic characteristics associated with these changes, and this is crucial for understanding whether the COVID-19 circumstances exacerbate health behavioral differences and point to where policy interventions are needed. I also want to point out that it helps guide what type of tailored interventions need to be developed to meet the needs of the diverse population groups in Canada that have been differentially impacted by COVID-19. So moving on to the methods of the paper, this study used data from the Canadian Perspective Survey Series 1, Impacts of COVID-19, which is a cross-sectional survey that was administered by Statistics Canada. And so a cross-sectional survey allows you to analyze data collected from a sample population at a specific point in time. And so the purpose of this survey was to collect information about changes in health and health behavior during the pandemic. And the data for this survey was collected from persons aged 15 years and older from all provinces between March 29th and April 3rd, 2020. However, for the purpose of this study, the authors chose the sample population that was restricted to Canadian adults aged 25 and older, which consisted of 4,319 respondents. And then to adjust for that reduced sample size, because they did restrict it to only people 25 and older, the sampling weights calculated by Statistics Canada were applied to correct for potential biases such as over and undersampling and non-response. So in this study, dependent variables included 6 items, measuring changes in health behaviors, including alcohol, tobacco, and cannabis use, junk food consumption, and inactive screen time, while independent variables included demographic, socioeconomic, and health-related characteristics. So these independent variables chosen are known to influence health behaviors in general or may moderate the impact of the COVID-19 pandemic on diverse groups of Canadian adults. And so further analysis using these various independent variables demonstrates the application of a diversity, equity, and inclusion lens, which is even more important now as we continue to see the deepening inequalities associated with COVID-19. And notably, by adopting such a lens, we are able to better recognize the complex circumstances that may affect Canadians' health and well-being, particularly among those who are most vulnerable, including factors such as gender, age, immigrant status, degree of financial impact, among other socioeconomic factors that were collected in this study. And so the analysis for this study was conducted in 2 phases. First, the authors characterized the target population with respect to key socio-demographic characteristics and described the changes in the health behaviors. And then they estimated multinomial logistic regression models of each health behavior as a function of demographic and socioeconomic characteristics. And for attendees who aren't aware, a multinomial logistic regression is used to model nominal outcome variables in which the log odds of the outcome are modeled as a linear combination of the predictor variables. And so now we'll highlight some key results from the study. Results showed that health behaviors worsened during early stages of COVID-19. For instance, the proportion of Canadians who increased their intake of addictive substances, junk food, or inactive screen time were much higher than the proportion who decreased these behaviors. It's also important to note that these changes differed across health behaviors. For example, alcohol intake increased for 14% of the population, while junk food consumption increased for 25% of the population. And this is likely due to various underlying factors such as socioeconomic status. So when looking at the association between socio-demographic characteristics and health behaviors, the study found that increases in negative health behaviors were more prevalent in younger compared to older Canadians. Canadians who experienced the financial impacts of the pandemic were more likely to increase their detrimental health behaviors compared to unaffected Canadians. Third, women increased their junk food consumption and inactive screen time compared to men. And then Canadians who identified as immigrants were less likely to increase their consumption of alcohol, cannabis, and junk food, and more likely to decrease cannabis and junk food consumption compared to Canadians who did not identify as immigrants. And so it's important to see that these findings align with what we're seeing in other studies regarding the deepening inequalities, and that they differ by factors such as age, gender, immigrant status, degree, financial impact, and other socio-demographic factors. So I want to take a few moments to discuss some of the strengths and limitations of the study. Some strengths of the study include that it used timely, robust, and representative data to really present a picture of what the Canadian population looked like at a point in time. It also addressed an existing gap in the literature by assessing the pandemic's disruption to daily lives and the long-term impacts of those changes. And this is an important gap because societal and economic shocks can have a profound impact on population health and well-being as citizens experience job uncertainty, changes to their daily routine, and feelings of insecurity. So some limitations of the study to highlight include that data on important health behaviors were omitted, such as race, ethnicity, and Indigenous identity, province of residence, duration of unemployment, family income, and they weren't asked, and this was because they weren't asked in the survey administered by Statistics Canada. So it was a limitation of the data. And then another limitation is the scope of some of the health behaviors also limited the analyses that was able to be done. For example, physical activity was not directly assessed, and screen time did not distinguish whether the changes were leisure or work related. So now I'll highlight some key take-home messages from the discussion that should be considered moving forward when developing public health policies and our interventions. So to develop policies and programs that address the needs of diverse groups of Canadians who have become particularly vulnerable during the pandemic, it is important to understand how health behaviors have changed during the pandemic, as well as how these changes have been exacerbated by pre-existing socio-demographic and socioeconomic disparities. Second, public health interventions should be developed to target the younger population to reverse the shifting consumption patterns and inactivity during the early stages of the pandemic. And this will ensure that these behaviors do not become permanent habits that in turn contribute to long-term chronic and costly health problems. And lastly, policies that mitigate against the loss of income have the potential to counteract negative health behaviors and thereby long-term ill health. And so I want to conclude with saying that this study did a comprehensive job at documenting the overall deterioration of health behaviors among Canadian adults during the early months of the COVID-19 pandemic, and highlighting how these changes widen existing disparities. And this really brings into focus the need to keep tracking the long-term effects of the COVID-19 pandemic in order to assess whether changes in health behavior improve or continue to worsen. Lastly, the results really highlight the need to develop and implement tailored interventions to ensure a return to at least baseline healthy lifestyles during the COVID-19 recovery period. And now we'll turn it over to Q&A and discussion with the authors.
I just want to encourage everyone to ask any questions you may have either through the Q&A box, and we'll answer those in sequence. In the meantime, we'll begin with some methodology questions. And so the first question is, so for those who might be interested in using Statistics Canada data, can you talk a little bit more about how the CPSS COVID survey and how sampling weights were used to correct for over and undersampling and non-response bias, and why this is important to do so with this types of data, especially given that the response weight was 23%?
I'm happy to take this question. So the analysis were Anthony and Matt and I did the analyses, but gentlemen, feel free to jump in. But so to give you a little bit of a background on the data, because some of you may be also interested in using these data. Statistics Canada actually did a really quick decision to use an ongoing survey, the Labor Force Survey Panel, which you probably are familiar with, and query a subset of their participants with COVID-related questions. And so, as you know, we went into lockdown March 15th, and this survey was administered, as Samantha said, at the end of March. So like 14 days after lockdown, which is really amazing. But the of course, for a survey that's done on such a short notice, the response rate was fairly low. As Samantha correctly said, 23% is the overall participation rate, which is a combination of the participation rate into the labor force survey and then into the CPSS wave 1 among the invited participants. And so why is a low participation rate a problem? Well, because people are not randomly selecting into the survey. So the 23% who responded are quite likely systematically different from the remainder who did not, and we don't exactly know how. So to at least balance this out, Statistics Canada used the respondents' socio-demographic information, their age, gender, educational status, and a number of other characteristics, and basically match them against the Canadian census, or against the Canadian population, and assign weights, which assign a greater weight to those who were underrepresented and smaller weights to those who were overrepresented. So if a large proportion of, say, highly educated older people responded, they would get a smaller weight. So overall, the estimates that we produce and that are produced with the CPSS data represent Canadian national averages. So that's a major strength of the data, even given the limitations of the low participation rate.
Oh, great, thank you so much. And so would you suggest any changes to the way the CPS COVID data was designed or collected that would have strengthened your analyses?
You know, I'm glad I'm not responsible for making it better, because I imagine that they did you know, everything possible to make it as good as. I think that the participation rate would have been hard to increase given the short time span. The one thing that we sort of wish the Statistics Canada considered doing was to collect really critical information, such as the province of residence, race and ethnic information, and maybe rural urban. They added rural urban in the latter series, but not race, ethnicity, or province. And those are really critical pieces of information, because COVID has had quite a different impact at different times over the past 11 months across provinces. And COVID certainly impacted visible minorities and populations across different race ethnic groups drastically differently. So not having that information has really weakened the power that these data could have had to inform policy.
Thank you. And I see that we have a question from the audience. So an attendee asked, thank you for a wonderful presentation. I'm curious about your models. Did you utilize one model and then include the other social demographic variables as covariates? If so, are you concerned with issues related to the table 2 fallacy?
I don't want to sort of take over. Anthony, would you be interested, or I don't mean to be throwing you under the bus, but I want to share this is a nice question, how we did the modeling.
Are you able to answer that question?
Sure. I know I had to look. Sorry, everyone. It's been a while. We've done a couple of other COVID papers. So both of us are, I went online and I downloaded the paper and I read it closely to remember. So we ended up, I think actually our main models are straight up just multinomial logistic models. We did not build them step by step. If whoever asked the question, please let me know if I'm not answering your question. We did not build them as a nested series because we were in a situation where we had 6 outcomes and we had this multinomial situation. So as Samantha alluded to, a multinomial model is a model that's appropriate for a nominal outcome with more than 2 levels. So we modeled jointly the probability of decreasing a given health behavior relative to no change and increasing that behavior relative to no change. So these tables bulk up really quickly. So we just presented the fully adjusted models rather than build them bit by bit. Does that sound
I'll wait for that person to respond. But in the meantime, I'm curious, I have a follow-up question to that. And so you mentioned that you have, in your paper, you use 10-year age brackets for your, of your sample. And so I'm curious to know, and so oftentimes we talk about the inclusion of either categorical continuous variables, and usually age is something that's included as continuous. But I think one really important thing to highlight here is when we think about modeling, it's always important to kind of think about what implications that might have for your study questions and the I guess the things that you want to think about, I guess the objectives of your research and what you wanted to do. So I'm curious to know what your thinking was as to why to treat age as a continuous variable within your models and what implications this may have for your study's research objectives, especially as we think towards things that are amenable to policy.
Oh, that's an excellent question. Anthony and Matt and I think, tried specifying age different ways. So Statistics Canada, for the purpose of these data, and this happens in many data collections, does not collect individual or single years of age, but typically groups age in 5-year groups and often 10-year groups. And the latter was the case in the CPSS, all of the series. So we did not have more detail than the 10-year age categories. We did not model them continuously or linearly. We included the however many, about 6 or 5 dummies separately into the model because we sort of were wondering about nonlinearities. We have these young adults, middle-aged, and then we have people who are retired who may have been affected by COVID in a very, very different way. And we didn't have enough of a signal across the 6 outcomes to be able to say that there's something clear happening 65 plus or not, but there was a clear age, generally speaking, gradient. Is it linear? I wouldn't go as far as saying that. Matt or Anthony, feel free to jump in anytime on these modeling issues. You've played with the data a lot too.
Sure. That's sort of, I guess, one of the limitations to public use data in general is that there is not really the option to measure age as a continuous variable. And then also, I guess, because there is no, as Anna suggested, there is no sort of linear relationship across any of these outcomes in terms of as age increases, there's not like a steady or like a straight linear relationship. So we thought that it would be better just to include them as a dummy variable rather than as a continuous measure of categorized ages, I suppose.
And I'm curious to know, so do you think that that particular presenting of the results is particularly helpful for when you're thinking about in policy, like making things amenable to policy and having targeted interventions for survey? Do you think that's particularly helpful?
Well, to be honest, I think that what is more useful for policy in this case with respect to age is simply the pattern that we're seeing younger adults being hit harder than older adults. And again, it's not that we are discovering something nobody else has described, but our results contribute to the growing evidence that the COVID has been particularly, not that it wasn't hard at older ages, but that in many ways, people who are just starting their careers or education or sort of going through higher education may be hit particularly hard, sort of their life trajectories being disrupted and perhaps more so than at some other ages. I don't know what,
I agree with what Anna was saying. I think it's important to identify these different segments of the population, so to sort of identify that younger adults are being affected more than older adults by the pandemic. It would be important for anyone interested in doing any sort of implementation of new policies or health interventions or these types of measures that in order for them to do like a more targeted approach. And it's something that we found in various papers that we've done actually on the impacts of COVID-19.
Mm-hmm. Thank you. And I ask because I think sometimes it's really important to discuss how, like, sometimes that the decisions you make around modeling, sometimes how they trickle down to meeting your study objectives and to also thinking forward about how you can apply the research. So that's super helpful. And then another question. So we haven't talked about missing data methods within our journal club sessions yet. And you talk a little about using complete case analysis and why you felt this was an appropriate, and so I'm curious to know why you felt this was an appropriate approach given your data, as well as what was the assumption made around the missingness of data?
I can try to answer that question again. The missingness was very low in this sort of survey series in general. So we didn't really find that just because of like it was very low proportions, like 2-3%, something like this, that we didn't find that there was any sort of complications in terms of missingness. And we sort of assumed that it was safe to do like a complete case analysis, as the assumption was that these responses were missing at random.
And I'm going to pass this over to Samantha to see if she has any questions to ask you guys as well while we wait for more things to come in from the audience.
Yeah, so I have a few questions that are more policy related, but the first one is, what type of public health interventions would you implement to address the various behavioral changes and underlying inequities that you identified in the study?
I think in general, one of the main takeaways from this is that health risk behaviors could be used as a coping mechanism to deal with the uncertainty and insecurity associated with COVID-19. So a very general blanket policy would be to increase economic support policies that protect against loss of income. That would help ameliorate some of the stressful impacts associated with COVID, as I've previously mentioned. But also, and some people might not like this, but I think also limiting the amount of access to cannabis, tobacco products as well, in particular, given that it is COVID-19 is a virus that attacks the respiratory system. I don't think that tobacco and inhaling anything in your lungs is going to benefit you over the long run. So that's just one thing I thought of. But again, I think the biggest takeaway is bolster the economic support policies around helping those in the most vulnerable population groups.
Matthew, you just mentioned that, limiting access to certain substances. And I mean, public health is already viewed in a paternalistic light sometimes. And so if you were to do something like that, how would you deal with the pushback? Because that would definitely become politicized.
Yeah, I'm not a public health expert. This is just something, it's more of a personal anecdote, but perhaps someone like Howard could expand on my idea there. But again, I'm just throwing things here, just some ideas around.
I think that, there's different strategies and policy of direct limiting of access versus kind of the framing around access. And, one of the things that's really interesting about this study, when you look at it in terms of both the age component and the economic component, is there's some evidence that when there's time, people fill their time with bad habits as a coping mechanism. And so here I think that there's some intervention that can be made around education on what you do in that time. And kind of Matt alluded to, I think one of the interesting findings of the paper that seeded at work that the group did later is the role that economic interventions can make to try and offset some of the mental health elements.
If I may follow up on Matt and Howard's comments, what they've alluded to, we actually looked at the economic support indirectly. And in a different paper, our team also looked at the changes in mental health between this very early April and May. And what we found was that mental health deteriorated, but actually people's economic worries lessened, and those were related to the mental health. So if the economic supports weren't put in place like they were, mental health would have had deteriorated even further among Canadian adults. So we actually have results that show the relationship between the CERP and other supports that the government put in place and sort of lessening of the mental health impact.
Another question I have is, public health is quite interdisciplinary, and we see a lot of departments coming together or sectors. And so how can we convince decision makers that social investments, such as investments that mitigate against the loss of income, are public health interventions? We tend to silo off different sectors, and how can we really bring them together?
Well, I think that in most policy considerations, it's about being able to show the solution rather than the problem. And I think that the work that this team's done has shown kind of points to where solutions are. And so it's a matter of asking a question of, okay, there's some early warning signs in the analysis of this paper, which is the first part of the pandemic, that shows where people are going to put their energies. And so you can then predict down, not necessarily in a statistical prediction, but in a policy prediction of, okay, if this is going to be what's happening, and you take the demography of a problem, this is where we're going to end up later on. And some small tweaks can really begin to change that in terms of raising awareness of the importance to keep busy. In the early part of the pandemic, it was a very draconian, everybody stay at home, don't leave, don't go to the parks. So one of the easy policy solutions was, okay, let people out to the park. Screen time, again, what people weren't contemplating, those kinds of things. So I think it's about making those kinds of translations to be able to kind of point the results into directions that people are already looking at, so that they can then act on them and offer some solution.
The last question I have is, sometimes there's a bit of a gap or a disconnect between policy and research. And so what are some strategies that you could employ to better get your research into the decision makers' hands and get stakeholders to buy into these solutions, such as the public health interventions that you're proposing?
Well, an event like this is certainly a huge step in the right direction, with a number of attendees, early career people who are sort of seeing the connections and hearing about the connections between research, very timely research, and policies that are developing in real time. Maybe Patrick, you could talk about your experience with discussing your other COVID-related research, which also had a huge impact, and so in terms of knowledge mobilization and speaking to the broader audience.
Yeah, I think one major component of that is not limiting our work to journals. I think going through the journal publication process is really important. It refines our ideas. It tests them. It subjects them to scrutiny. But then to think beyond. So as Anna mentioned, some of our other work, we made sure to sort of pair them with op-eds, so in the conversation or other kind of outlets like that, to be more proactive in engaging with policymakers. So whether that's reaching out to them directly or through some of those more popular media outlets, like like blogs or op-eds in newspapers, or events like this, right, where the information is being packaged in a way that's a lot easier to understand, that maybe policymakers and just members of the public don't have to sift through some of the statistical details, but really engage with the meat of the matter. I think these are all useful ways of doing it. And I think, as Anna mentioned again, this particular moment in history and this particular crisis we're facing has lent itself, if there's any bit of silver lining, to this kind of reaching out from the research community to policymakers and the wider public.
I would just add that this is absolutely the case. But in addition to, when Patrick mentioned, members of the public, oftentimes our work is behind a paywall and costs a lot of money, and people are not going to be paying $40 an article. But again, as you said, Patrick, many of us ended up really for the first time in our careers putting things on preprint servers. And those are publicly available and immediate. So we finished the paper and posted it on the preprint, and then the article could wind itself for months through the review process, which is an important step because it shows that our peers also find this research to be rigorous and valid. But in the meantime, whoever wishes to access the results can do so easily for free, just Googling the topic.
Sorry, I'm on mute. A question from the audience. Can you expand on why you think that we're seeing that in immigrants, the deterioration of engagement in health behaviors is less pronounced?
I can start, although we all could answer this question quite well. So I imagine that everybody in the audience is aware of the health immigrant effect, or the tendency for immigrants, especially newer immigrants, to Canada, to the US. This is a fairly general phenomenon, to both have better health and also to have healthier behaviors, or better health behaviors. So we think that that's an extension of this tendency to sort of lead healthier lifestyles. I would also venture, this is pure speculation, we didn't have data, but whether it's possible that people in immigrant families might potentially have more social support within their sort of physical bubble that was allowed, maybe less likely to live by themselves, and so not have the loneliness on top of the restrictions. But again, I caution that that's speculation, and my colleagues may have other suggestions, ideas, or intuitions.
And I'm particularly interested actually in Dr. Dees. I know you do a lot of work with workplace issues. And so I'm even thinking about perhaps, again, speculation, maybe the link between essential workers and immigrant families and how that might also affect their healthy behaving. Maybe they're not as home as much, or I'm curious to hear your thoughts on that.
Potentially, I think, that could sort of go either way, right? Essential workers or those who work in frontline occupations may experience higher exposure to the virus. They may also be working in occupations where they're less likely to be able to work from home, right? And so on the one hand, you could see that those are maybe potential contributors to the faster spread of the virus. And in fact, in some other work, we find that places that have a higher share of immigrant populations also tend to have a higher share or a higher number of COVID-19 infections. At the same time, this particular paper is looking at changes in healthy behaviors. And so, keeping up with the routine of going into work, getting the social connections that going into work and actually having to go to a place of work brings, as Anna mentioned, these may also be contributors to, stronger, more consistent social networks, which might be protective in terms of these kinds of healthy behaviors that we're looking at.
Thank you. And given your background, I'm going to pick on you. I'm sorry, Dr. Ramos, in health equity. I'm curious to know what your thoughts are on this as well.
I think that it's a combination of the things that Anna were mentioning and Patrick. The other thing that I think is interesting in focusing on immigrants and is remembering the age component as well, which is most newcomers in Canada are in prime working or age. We have older immigrants as well, but if you look at the immigrant population, it's a younger population. And so I think that, if you have to be out at work, you have the social networks, you generally are younger and have other health behaviors that's going to offset some of the screen time or eating junk food, or, even for that matter, cannabis usage might be lower as well, given kind of regulation in home countries for many newcomers as well, where it might be still considered to be taboo. So I think those all kind of are bundled into the findings here.
Thank you. And so another question from the audience. So how do you think that these results from your study could influence the development and improvement of pandemic response in the future?
Let me start, and then I'm also curious about everybody else's thoughts. I would certainly hope that there is, that the results like these, and we are accumulating a critical body of evidence, would influence response. So in particular, of course, the primary focus was on minimizing the transmission rates, minimizing mortality. But at the same time, we now have a population from children to the elderly that oftentimes has become physically immobile for 11 months. What's that going to do to, rates of obesity, rates of osteoporosis, rates of, just anything that goes with physical inactivity, which is pretty much all chronic illnesses down the road? We don't know. And so of course, like Matt, I'm not a public health expert, and certainly devising these policies is probably a game of damned if you do and damned if you don't. But I wonder whether there is a way to balance these long-term mental health, domestic violence, financial stress, PTSD, sort of impacts that are sort of quietly simmering underneath, quietly not in the minds of those who are suffering, but in the sort of policy world, against the need to slow down the transmission and the mortality rate. Sorry.
I might add that, one of the lessons I think that is indirect from this study, but this study shows the importance of it, is being flexible and nimble with data. And what's really interesting about the data that was used in this study was, as Anna was saying, is it's an offshoot of a labor force survey panel. And I think that, I hope that's a lesson learned, that being able to repurpose and triangulate across existing surveys and things that are in the field is going to be essential to be able to capture those early portraits, to do, as Anna was saying, also then think about the knock-on effects that happen down the line.
I agree. And I'm also curious to know, as post-secondary students, Anthony and Matthew, if you have your response to the question. So what do you think? How do you think that these results could influence development of future pandemic response in the future? And thinking about you guys as post-secondary students, also, I believe, Anthony, your research interest in post-secondary education as well.
Well, I thought a particularly interesting finding that we didn't necessarily highlight throughout the discussion, but was finding that the previously married are a particularly vulnerable group. And if we think of the context of being divorced, bereavement, and separation, and that stress that's associated with that, and then you add a pandemic on top of that, it's no surprise that I think their tobacco product use was 3 times higher than those who were partnered. So I think, just speculating, but this reaches to a larger issue of social support. So those who are living in lone households or one-person households, I think should be, without repercussion, allowed to access one other bubble during times of lockdown if we, God forbid, go through another 3rd or 4th wave. I know in my home province, New Brunswick, they actually implement that policy, and it seemed to, anecdotally speaking, help those who were living by themselves.
What I found particularly interesting sort of in this pandemic type research that we're doing and identifying these different segments of the population was that it also sort of echoes findings in just the general population outside of pandemic times. And so I guess what the takeaway would be is that even though there's a pandemic, that these sort of hesitant to call them vulnerable segments, but like these different segments of the population remain in need, and that it's important that we don't forget about their sort of health and health behaviors that they are likely to engage with, such as people with lower levels of education and so forth. And so I think that's a large contribution of our paper in general.
Great, thank you so much. And I just wanted to ask here, I'm curious as to know, since this is the first time we've had a group of authors on here, I'm curious to know your decision, why you chose to publish with CJPH and your decision as to how that was for all of you. I think it's really exciting to have grad student here perspectives and also people who are early and mid, late career. It's the first time we had that, so I'm curious to know your experience with that.
Hi, Danielle. Congratulations on figuring out the video. Well, we worked together to generate a small set of potential outlets, and the Canadian Journal of Public Health is a highly ranked influential outlet, and our study substantively fits really well into the mission of the journal. So I think this was actually a fairly easy decision, and we're very glad that the editorial decision-making, and the reviews were positive, that we were able to satisfy all the basically conditions of publication.
Sorry. Yeah, no, thank you so much. And so I believe that we're almost out of time. And I want to thank you guys. Thanks, Samantha, for a wonderful presentation. Thank you guys all for your wonderful discussion. I hope that the attendees, I sure did enjoy this discussion. I hope the attendees did as well. I'm just going to promote our next Journal Club session, which is, so we'll be talking about on March 31st, a paper called All Together Now, aggregating multi-records to develop a person-based data set to integrate enhanced effective disease surveillance in Ontario. So CVHA members can register for free through the link, and non-members can register at the CVHA website. And if you aren't currently a CVHA member, I encourage you to consider joining. So membership is a great way to connect with Canada's public health professionals, such as people in this webinar. And there are many benefits to joining, including student opportunities like free access to webinar series, eligibility to participate in our mentorship program and leadership roles. And so if you're interested in becoming a member and learning more about what the CVHA or what public health has to offer in Canada, I'd be more than happy to have a one-on-one conversation with you. And please feel free to reach out by email to me at students@cvha.ca. And just on behalf of everyone at CVHA, I just want to say thank you.
Thank you, Monica. Thank you, everybody. That was a really great webinar. Thank you, everybody, for your wonderful questions. And unfortunately, we do have to finish a few minutes early today, just for a scheduling conflict that we're having on our webinar platform. So apologize for kind of swooping in here and cutting things off, but I'd like to say thank you, merci miigwech, to our presenters and moderator, and to all of you for joining us today. As mentioned earlier, you'll all receive an email notifying you when the recording of today's session is available, and previous sessions are also available on our YouTube channel.
Thank you very much for having us. It was really wonderful to get audience questions. And Samantha, thank you for a terrific summary. We couldn't have done it better.
Yeah, she did a great job. And we also, CPHA recently provided a review of Canada's response to the COVID-19 pandemic, and it's available on our website. It also offers quite a few recommendations for moving forward. So thanks again, everybody.
Thank you for having us.
Yes, thank you.
Thank you.
Thanks very much. Have a great afternoon, everybody. Stay safe out there.
Bye.
Okay, bye.